one-hour session this time. So I'm absolutely delighted to be involved with today's Global Health History Seminar, which is the number 107, which deals with cultural contexts of health, vaccine hesitancy, why do some people not vaccinate. The speakers will present slightly differently. Robb will speak for 10 to 15 minutes, and Heidi will speak for about 20 to 25 minutes, or thereabouts. And then we'll open the floor for questions, but we will also have questions online through Twitter and through Slido, which our dear colleague Priya will help us with. So please use Slido to put your questions to the speakers, or vote on another question if it gets asked. If watching online, please scroll down past the streaming window to find the Slido interface below. And you can also upvote a question if you think it's important. The GHH seminars have been running for over 10 years since the first one was in 2004 and has been generously funded by the Wellcome Trust throughout. The series is organized by the University of York's WHO Collaborating Center, which I direct. My name is Sanjoy Bhattacharya, and I'll be facilitating the session. The series was originally based out of WHO headquarters in Geneva, but then moved to WHO Europe, where it is now based. But we work with offices around the world from Copenhagen, and really enjoy working with WHO country offices all over the place, not just those in Europe, but for instance in South Asia. The aim of the series is to bring together experts from the humanities and social sciences with senior officials from WHO and other UN agencies to exchange ideas and perspectives on important global public health topics, exploring the social, historical, and cultural context of health. The series is aimed at the global public health community, national governments, international media, and the general public. And as you know, it's streamed live on the internet, so people can join us and be a live part of the question and answer sessions. We believe that the understanding of historical and cultural context of health helps public health communities better respond to today's challenges, and it helps shape a better future for everyone, especially those most in need. The Cultural Context of Health project has been crucial to the running of the Global Health History Seminars. And here, Euro's Evidence for Health and Well-being in Context project has been a very valuable partner. And it's this project that includes the Cultural Context of Health stream, which Niels, I think, is on holiday today. So it's one of those rare occasions when he and I are not co-presenting these events. The project in Euro advocates the importance of taking into account how culture, in a widely understood sense, affects health. Cultural context of health promotes knowledge and research that captures people's lived experiences and contextualizes lifestyle choices. In so doing, cultural context of health stresses the need to better integrate the humanities and social sciences into the work of the WHO. And as many of you, I'm sure, know, that there are 4 focus areas: nutrition, well-being and mental health, migration, and environment. So, very quick introduction of our speakers. Robb Butler is Program Manager in the Vaccine, Preventable Diseases and Immunization team, the Division of Communicable Diseases and Health Security in WHO Europe. Robb is a social scientist managing international public health, humanitarian assistance, risk and crisis communication, and social protection programs. Robb has over 20 years' experience with behavioral insights, sociocultural investigation, and intervention in Asia, Africa, and Europe. His interests and expertise cover social science interventions in public health and societal safeguards, risk communication, and behavioral insights. He's widely published, and I'm sure those who are interested can get in touch with Robb for more information on his publications. And academics people, I think, complements Robb's areas of interest wonderfully. We have Professor Heidi Larson from the London School of Tropical Hygiene and Medicine. And Heidi is an anthropologist and director of the Vaccine Confidence Project, professor of anthropology, risk and decision science, Department of Infectious Disease Epidemiology at the London School. And she's also associate clinical professor, Department of Global Health, University of Washington. Dr. Larson is also a fellow at the Chatham House Center for Global Health Security, which is headed by an ex-WHO colleague, David Haymond. Heidi previously headed the global communication for immunization at UNICEF and chaired the Advocacy Task Force for the Global Alliance for Vaccines and Immunization, Gavi, and served on the WHO SAGE Working Group on Vaccine Hesitancy. Her research specializes in the analysis and evaluation of health and development programs, with particular attention to social and political factors that can affect policies and programs. Her particular focus is on risk and rumor management in health programs and technologies, especially vaccines, from clinical trials to delivery and building public trust. I'm sure those who are interested can get in touch with Heidi for more information on her vaccine confidence project, as well as any publications that might interest you. And we do mean this. I mean, please, if anyone follow up with us, we'd love to talk to you. Such interaction usually allows us to learn a lot more as well. So don't be shy. And Robb, please, the floor is yours.
Okay. Thanks very much. Right, so what I'm going to be, I'm wondering, can you guys see this from there? You can? Okay, so I can't move around. Okay, so I'm going to be speaking about vaccination, demand, acceptance, and hesitancy. And what I'll be doing is actually looking from this end of this continuum to start off with. I'll be looking at the people that demand vaccine, those that passively accept vaccines, and then a little bit on vaccine hesitancy before Heidi, who I might say it's an absolute privilege to present alongside because she's been a mentor of mine for years, will take us on a deeper dive into vaccine hesitancy, particularly confidence, and those that refuse vaccines and anti-vaccine sentiment and lobbies, and the history of those slightly. So I'm going to start here with demand and passive acceptance. And acknowledging that a lot of you are not vaccines people, I'm going to try and keep this talk fairly light in terms of content. So I'm going to start here. So we remember Meg Ryan faking her orgasm. We remember Billy Crystal being incredibly embarrassed about her doing this in a very busy diner. Can we remember what the old lady said in the background after she had faked her orgasm? All right, good job. 10 points to you. I will keep score. So I'll have what she's having. This is a book by Alex Bentley and colleagues, which is very much about mapping of social behaviors, but it specifically positions social copying in this book. It goes into depth on social copying and how we copy each other's behaviors as human beings. And what Alex and his colleagues argue is that some of our decisions, this is your decision map or your behavior map, some of our decisions are very well informed, some of our decisions are very poorly informed, some are individual, and some are social. So if you like, any decision or behavior that you follow today could probably be mapped somewhere on this axis. For me, his presentation that he gave about 4 years ago was very enlightening because he scribbled this on a whiteboard and it really resonated with me because it's very similar for me. For a start, we have down here my independent, autonomously, and very poorly informed decision on auto insurance. I have no idea why I have the car insurance firm that I have today. I feel that it's an independent choice, but I don't feel it was very well informed. Up here, we have a more rational decision around being well informed, independent, autonomous with my decision making on deodorant or perfume or whatever. Up in the right-hand corner, we have a lot of social copying, and that's very typical of me. Social copying around which charity I donate to. I haven't done a lot of research, I haven't done a lot of background analysis on which charity could really benefit from my small pennies that I give to charity. But I go with very much the social norm in my peer group and my community. And I feel that that's fairly well informed because I consult my peers on it. And then down here I have my music taste, which is really bad, and which changes so frequently according to which way trends and fashions go. I hold on to a little bit of my music taste from the dark Thatcherite 80s, but most of my music is determined by those around me, and even my 12, 14-year-old daughters very much influence what music I listen to, and a lot of it is rubbish. And a lot of decision making happens down here in this little box where we have a lot of social copying, a lot of poorly informed decisions. Why am I telling you this? I'm telling you this because I would argue that a lot of vaccination decision making is made right there. It is neither well informed, it is neither poorly informed, it's just done. People copy each other. They don't think a lot about why they vaccinate their child. And we're reasonably happy with that in most countries where we have 90-95% uptake or coverage of a population for vaccination. We're very happy with that because people copy each other, right? So if the majority are vaccinating, then we'll probably be able to maintain that vaccination coverage. But it makes our programs incredibly vulnerable, this position of social copying around vaccination decision making. So we assume that this is the majority of the population who do demand, or who do receive vaccination, who are vaccinated. And down on the right-hand side of the axis here, we have those that are not vaccinating. So we believe that when we have a vaccine safety crisis, or we have a concern with a vaccine, that concern draws our majority of our population across that axis into the more red zone. Draws it across the more red zone, and that we try and tug it back with our communications campaign. And we believe that this is, and as long as that little red zone down there remains below 5-10%, we maintain herd immunity, we're less likely to see outbreaks. That's how we believe it happens. But if we take my position of social copying and were to just suppose that that could be the case, what we actually see, and what we've seen in very prominently in a few member states, most notably the one in which we're sat at the moment, Denmark and Ireland, around HPV vaccine over the last 3 or 4 years, is this actually happens. As the two pulls come, we see groups here copy each other's behavior. They don't simply come across to the safe side of the zone. And this grows. This is called polarization. We see a polarization in our population with regard to their vaccination decisions, and our program is then at risk because we have more people under or unvaccinated and a larger susceptible population. So what we have to find a way in the future of doing is anchoring, and I'm going to come back to this shortly, anchoring the population so that when this tug comes, when we have this vaccine rumor that Heidi's going to talk about a little bit shortly, we try and build a resilient future community to these rumors and to these events that occur. We know that behavior is contagious. You all in this room know that we have we think about epidemics in terms of biological notions. We think of epidemics in terms of, there are crime and fashion epidemics, I could say, contagious behaviors, consumer behaviors. But health-seeking behavior itself is extremely contagious, and there are all sorts of things that are incredibly contagious and are as contagious as viruses themselves. If I say the word yawn, if you read the word yawn, if you look at pictures of the word, I've got 3 so far that have yawned. Okay. That's the most interesting about yawning, for those of you that, of course, read Gladwell, will know that those that the blind yawn when they hear a yawn, and the deaf yawn when they see a yawn. Is that contagious? It is phenomenally contagious. But what's interesting in this is possibly the 4. Now I have 4. The 4 people that I've actually made yawn in this room, it's less interesting to me as a behavioural scientist that you're yawning because I've yawned, because that's clear, it's contagious. What's more interesting is what's gone through your head over these last 15 seconds. So you've probably thought, oh, I didn't have much coffee, I didn't sleep well enough last night, Rob is an incredibly boring speaker. You could be thinking any one of those 3 things right now. And what's interesting about that is that my action has learned you, and so the behavior has actually taught you something. So it's not learning and then behaving, it's behaving and then learning. And I would argue that a lot of people are vaccinating without thinking about what they're doing. And I would also argue that many of them are behaving and then or vaccinating their children and learning about vaccines sometime later on in life. When the decision's made, in other words, it's not necessarily the most well-informed. And these individuals do not sit down, the parents, I can say this safely and securely from my wife and I, we did not sit down and have a long, drawn-out discussion about our child's vaccination. We just did it. And you could say, okay, well, you work at WHO, we can understand that. But most people behave in the same way in that respect. But of course, some people do not. There are those that do not automatically, intuitively vaccinate their kids or vaccinate themselves with vaccines for older populations. And we have this hesitancy that we're going to talk about shortly. Vaccine hesitancy, as defined by the SAGE Working Group on Vaccine Hesitancy, of which Heidi Larson was a member, and I sat somewhere in the periphery, in the corridors, and listened to with a lot of interest, define vaccine hesitancy in the following way. It's complex, it's context-specific, it varies across time, place, and vaccine, of course, and it is determined by elements of complacency, confidence, and convenience. I'll unpackage this in a moment. It's complex. It's incredibly complex. Vaccine programs are very complex things. Delivering a vaccine and administering a vaccine in an arm after the phenomenal journey that vaccine's made, from production facility to procurement, to arrival, to storage, to cold chain, all the way through to the healthcare worker delivering it in the clinic. It's a miracle that we have the technology to be able to do this. But it's incredibly complex, hesitancy. The reasons why people do and do not choose to vaccinate could be determined by any of these factors and a whole mix of them. And I'm not going to unpackage this, but to say that it is extremely complex, it is particularly context-specific, and possibly when Heidi goes through some of the examples that she'll talk to you about, you'll understand what I mean by context-specific, because of course it is culturally, socially, historically determined, many of these decisions. So complacency, confidence, and convenience. Complacency. If you've never seen a vaccine-preventable disease in your community, you're less likely to be concerned about that disease. You become complacent, apathy sets in. I'm sure that if I went to my mother's home community on the Isle of Man and I asked people about measles today, half of that community would probably tell me that measles was eliminated decades ago, because they haven't had an outbreak, they haven't seen cases of measles, they don't see so much press on measles in the local press. They've probably become quite a complacent community. And if you're complacent, you're less likely to vaccinate your children, particularly if you have a concern around the vaccine, even if it's a very small concern. If you don't feel you need it, why would you do it? There's complacency at a healthcare worker level. As we've shifted over the last 40 years from a more practice-based to more theory-based medical curricula and education, fewer and fewer new GPs that hit their practice know what a case of rubella or know what a case of measles actually looks like. So there's a problem and a complacency at that level. There's also political complacency. where we see the political commitment and the securing of finances for our immunization programs declining over time, particularly in countries that have not been witness or suffered the phenomenal health and financial costs of an explosively large outbreak. So if you haven't had an outbreak, you don't see cases, you're less likely to invest in that element of your health program. It's basic, it's basic complacency at a political level. So complacency is playing out in different ways. And indeed, we've had over 100,000 cases of measles in the European region over the last 5 years. We've had a resurgence of pertussis. We've had two countries that have seen circulating vaccine-derived poliovirus over the last 6 years. And only in 2010 did we see over 4,000 cases of wild polio occur in this region, in Tajikistan, and 4 other member states that were affected. So these diseases have not gone away, possibly because we have a degree of political complacency occurring in these the member states that have every ability to just shut these diseases down. They have all the resources, they have the human and financial resources at their disposal, but in some cases they choose not to use them. There's a convenience factor. The second C, if you remember: complacency, convenience, confidence. There's a convenience factor. It's two busy parents today. It's hard to vaccinate your kids if you live in an urban area, both working, particularly if you live in an urban area. My GP Fleming, who works out in Temporal, I think I see him about once every 18 months, and I had to bashfully, embarrassingly, had to go into his practice and tell him that I was late for Flora, my second daughter's second MMR vaccine. Imagine how embarrassing that is when you walk in from WHO. Okay, so my head's down and I apologized to him, and I'm sorry, you know, I'm 6 months, 12 months late, you know, this is, I was looking for all these excuses of which I had no excuse whatsoever. And he turns to me and basically says, "But you're my hard to reach population." I'm like, okay, that's interesting. Why not the second, third generation immigrants? How do you reach them? Oh, they're fine. I reach them through the mosques. They have a strong oral tradition in those societies. Culturally, they're very adhesive. I don't see you, Rob. Your wife and you work. I've got no means of reaching you. You don't go to church on Sundays. Sorry, I don't go to church on Sundays. You don't have a very cohesive, adhesive relationship with the rest of the community, so I can't reach you. There's a problem here. I'm his hard-to-reach community, which is truly remarkable, but it's true. We have a lot of hesitancy amongst higher socioeconomic to working parent families, particularly in Northern Europe. This probably isn't the most convenient method of provoking the immune system. It's not much different than it is today. 150 years ago, this photo, well, the photo wasn't taken clearly, but the contraption is from 150, is dated 150 years. It looks slightly different today, but not a lot different. As a behavioral scientist, this infuriates me that science hasn't moved faster in this direction, but we do have a bright light on the horizon in terms of patches and microneedles that will help us be more convenient with the way in which we deliver this. And the other thing, this reads, "Putting on a brave face in front of the girls." It's a painful experience, yeah. It's not the most convenient. It's not the most convenient thing to go and get done. And as a parent, I can tell you, it is not the most happy thing to go and do with my kids. They're never happy to do it, and there is always an argument. And usually, both of us are crying by the end of it. So, so there is a convenience factor playing out here. This conveniency, and anybody that proposes that European health systems are in good shape in terms of convenience only has to listen to what you have to do in France to vaccinate your child. So in France, as Heidi just heard last week, and forgive me for repeating myself, but in France you make an appointment with the GP. You take your child out of the institution, take your child to the GP, make the appointment with the GP. GP gives you a prescription. You take the child and the prescription to the pharmacist. The pharmacist gives you a vial. You take the child back to the institution, take the vial back home and put it in the fridge. You make the second appointment with the GP. Take the vial out of the fridge. You pick the child up from the institution. Take the vial and the child to the GP for one child, for one vaccine.
Why so complicated?
Why so complicated, Malika? That's a great question. Why so complicated? But we have 5 countries that have a similar delivery system for their vaccination programs. So there is a convenience factor at play. Trust. Heidi's going to talk more about trust and confidence. And I don't know how much time I've got, boss. 2 minutes. Wow, I've got like 14 slides. Okay. So Heidi's going to talk more about confidence, but I want to talk about some of the heuristics that are going on. So, of course, we're not perfect information processors. 5 minutes, thank you very much. Thanks, Heidi. We're not perfect information processors. We have to translate our perception of risk, and we use various mental shortcuts to do this, various heuristics. And these often result in us making a bad decision or result in the wrong behavior. There are 6 very quickly. We have an effect heuristic as human beings and a simplification bias. We're guided by emotions, and we find when information and actions are easy to understand and conduct, we're more likely to change our perceptions and behaviors accordingly. And the anti-vaccine lobby understand this very well. They understand this because, they understand this in many contexts, and culturally this plays out, and Heidi will indeed go into this as well shortly. Of course, they can use this tactic. We also use the emotional tactic. This reads Lisa, blinded by rubella. It's a German campaign. So emotion and narrative is extremely potent. Unfortunately, parents are often left with very mixed messages because they hear the anti-vaccine, they hear the public health community speaking positively about vaccines, all these rumors, and everything becomes, well, good luck. I mean, good luck with making a decision. This is happening because with vaccines, we are indeed, as David Hayman's name came up earlier, building our boat and sailing it at the same time. The technology is changing so rapidly that it's an extremely difficult thing to communicate on when we communicate on vaccination programs. We have a confirmation bias. We're more likely to believe messages that support the conclusions that we've already come to. And once something has been anchored into a perception in a certain way, we filter new information according to this. The measles and rubella vaccine in Georgia had absolutely nothing to do with the sudden death of a 17-year-old boy. If you already believe this, this is what you read. The rest is yada, yada, yada. We're slowly understanding how we need to write better, how we need to communicate better. We have an issue with temporal versus causal association. So that is an event that happens after vaccination that we associate with the vaccine, but actually has nothing to do with the vaccination itself. An adverse event following immunization. And this is nothing new, as you can read from this Punch article from 1891. The assumption is here, of course, that the vaccine has taken the child's life. We don't, unfortunately, we kind of use the same tactics here, which would be nice. It'd probably get a bit of attention. She won a huge lotto prize after hepatitis B vaccination. It was just after the second shot, she said. My second child walked shortly after she was vaccinated. The miracle of vaccines. We're slowly understanding that when we receive and when we take a myth away, it's not just good enough to myth bust. We now know that it's very important that we replace that myth with information, and we also know that framing is very important as well. Which burger are you going to eat? They're the same burger, right? It is the same burger. You're going to choose probably the burger that's 75% fat-free in the same way that you would receive and you would accept a vaccination that is 99.9% safe. You might be less likely to accept that same vaccine if it was communicated to you in a different way. Unfortunately, healthcare practitioners in the European region still don't understand the importance of framing messages. I've gone on too long, so I think I'm going to stop because maybe the point I'm trying to make here is that we have omission bias taking place also in Europe today, where we see parents keener to avoid any risk or side effect to the vaccine, and therefore avoiding and missing out on gaining protection from immunization. Trust is something that Heidi's going to talk more about, confidence. Suffice to say that we all know, because we've lived in Europe, most of you, for some years, that once, of course, it's lost, it is incredibly difficult to regain. So my thanks to Heidi also for presenting alongside me today and taking us down the next part of the track, which is going more into confidence, trust, refusals, and maybe a closer look at this little bubble down here. Thank you.
Heidi, floor is yours now. So, yeah. Is your mic on?
Traveled up. Did it? Good, great. Thanks, Rob. I was actually enjoying what you were saying a lot. Or maybe I should go on this side to, oh no, the slides are here. But he was referring to a talk I gave last week, which I'm not giving now, but that's okay. The principle's the same. Sure. I've been giving a number of different talks in the last couple of weeks, and to keep myself motivated, I change it. So I've changed it. So I'm really glad that Rob covered a lot of the areas that he does, because I'm going to take a bit of a different twist, which is looking a bit more at the history. This is not new. I think that Rob has already mentioned that the middle, that came in from another slide, sorry. But basically the notion that vaccine is a delusion is goes way back. I mean, this was 1823 to 1913. So history affects this whole realm of particularly the questioning and the refusing from the moment the whole concept of vaccination and immunization were being configured. I mean, think about it. You take some virus from a cow and you put it in a child. That can't be warm and fuzzy. That can't be free of questioning. And we were talking about this earlier. I think there was a SAGE recommendation earlier this year, which I thought was pretty outrageous, which was that we should be preventing vaccine hesitancy. Well, I think that's a criminal way to say it, actually. I can say that now that I'm in an academic institution. But we can't prevent vaccine hesitancy, nor we should prevent nor should we prevent vaccine hesitancy. Any responsible parent with a first-time child should be asking questions, should be responsible to understand what they're giving their child, whether it's a medicine or a vaccine or anything. So the last thing we should be doing is shutting them up. And it's one of the biggest reasons we're in the mess we are right now, because it's payback time, I think, for years of take this, it's good for you. Oh, it's totally safe, don't worry about it. In this current environment, I mean, just open the newspaper, listen to the news. These histories are all falling out of, the truth is coming out in every way, from the sexual behavior of football coaches to Me Too movement to all kinds of things, histories of corruption and whatever. And oops, the truth of vaccines coming out too. So we can't say one thing and not really mean it. I sat in on a BBC morning show. Actually, it was also again this morning, but thankfully I was here. It was Victoria Derbyshire. I don't know, anyone's British, apparently it's quite a popular show. And they asked me to come and talk about this issue on their morning show because there had been a lot of measles outbreaks. They didn't tell me who else was going to be on the show, and I sat there with a young woman who I could already tell we were going to have an interesting discussion when they came to powder our noses before we went on air. And this woman said, oops, no. I have my own powder. And I think it must have been like whole wheat or something. But it was, I said, okay, we've got an interesting discussion. And then I learned that she had her baby delivered at home, and she didn't eat anything that came in packages, and very pure, which goes way back in the history of vaccination. Purity and liberty. These are two, if we had to define two themes from the moment vaccination started to now, among others now, we have a lot more now, but these two strong themes, anything that's natural is better than a vaccine. That's been since day one. And who are you to impose that on me? I want to make my own choice. The anti-vaccination leagues were actually initially anti-compulsory vaccination league. It was about the mandate. It was about the compulsion. There were other issues about the vaccine, but purity and liberty. But this goes, again, way back. The other thing is, here they talk about commercialism and its dangers, big business. That's another one that, as we have more and more vaccines in the pipeline, and very expensive vaccines, it used to be vaccines were the kind of the cost-effective. Now when people say vaccination is one of the most cost-effective health interventions, not really. It depends on which vaccine you're talking about. It depends on what disease you're talking about. So we need to change our narrative with the evolution of the immunization pipeline. Two things have dramatically changed the landscape, building on this initial resistance and questioning around purity and liberty. We have a rapidly changed communication environment, which you all know, highly interconnected, increasingly image and video based, which adds a emotive dimension that the text doesn't get across in the same powerful, moving way. Globally, it's not just, for a while there, we were like, oh, they don't have that in Africa, let's stick to flip charts. It has gone quicker in some places in the world, which a lot of us hadn't thought about because we were used to the business plan that you had to do when you get a phone. When I worked at WHO headquarters, I remember getting my mobile phone there. I had to give them half of my life history, my job contract, a guarantee I could pay. It was a stack of documents like that just to get a contract to have a phone. I had to have a contract, which that business plan went out the window in Africa, actually. That's where the whole idea of pay-as-you-go came from. It didn't come from Copenhagen or Geneva or New York. And we've actually adopted it up. But that's become ubiquitous. And there are some of the remotest areas of the world that are online. So that whole landscape has changed in terms of the potential for the spread of sentiment. We'd like to think it would be for good sentiment, but it's a rumor thing. The other thing is the whole field of vaccines and immunization has changed dramatically and continues to change. But after the initial launch of EPI in the 80s, and the first 6 that were in fact incredibly, I think of a measles vaccine was, when I was at UNICEF, I think it was like 7 cents for a generic measles vaccine. Indeed, incredibly cost-effective. It was easy to hand that cost over to the government because it wasn't a big budget line. It was a very affordable thing. That is absolutely not the case anymore. And we see it with the HPV vaccine. We've had all these demonstration projects around the world. I think 3 poorer countries have gone past the demonstration project. Who can afford it? And I think that we have to think about that in different ways, frame it in different ways, and we haven't caught up with, there has been absolutely a disproportionate investment in research and development of new vaccines and new technologies, and somehow dropped the ball around the social science, the communication, the mobilization, except for polio, in the vaccine space. So one of the things Robb and I have had a lot of discussions about is how can we re-energize this? We haven't kept up with this. So when the woman next to me in the Victoria Derbyshire program sat there and she said, and it came to her question, she said, they all lied to us, they meaning the health authorities. They still tell me it's 100% safe. Am I stupid? And it was just, it's so captured, and that was an easy one for me because I agreed with her. I said, you're right, walking out the door in the morning is not 100% safe. But we need to be more transparent about it. But this is the other big one, is motive. Robb talked about trust. There's two things that define a trust relationship, and trust is about a relationship. Hopefully you trust yourself, but that's a whole different thing. But trust is about a relationship, and there's two main domains. One, when I think about whether I trust my GP or my neighbor or the school teacher, it's, do I trust they're capable of what they're saying that they can do for me? Are they able? And two, are they interested? What's their motive? Are they interested in the best interests and health of my child and my family, or are they making money? There have been a number of GPs killed by their patients in China in the past few years because of this feeling that they're just in it for the money. It's been one part of the fallout of the shift from a more communism and free medicines and vaccines and whatever to a more capitalized economy where there's a transaction cost, which has instilled this sense of questioning what's the motive, and we don't weigh that in all the time. Anyway, this goes way back. We often talk about Jenner and the smallpox vaccine, but actually Pasteur and his experimentation and introduction of the rabies vaccine even went back a bit further. But actually there were also these anti-vivisection society, that's really more about animal experimentation, but is related because it's all connected. There are other domains of One Health, animals and humans, which is another part of the anxiety is that the whole vaccine process is connecting animals and humans, and that must be interfering with God's plan. This, I was reading to Sandra and Robb before, I think this is absolutely the story today. It happened to have been written in 1895. I shall do my best to be frank and fair and starting that I've carefully read and considered all the anti-vivisection. This could be the same as anti-vaccination. It happens to be with some of the trials. I would begin by pleading for calm consideration of the matter, which I think one of the challenges right now is that the emotive polarization, they're ignorant and stupid, oh, they're not being honest, the extremes is not helping our discussion. We want less heat and more charity. Let's maybe listen to what the other side has to say. Maybe there's something in it. I think that this is more discussion on it, and I don't want to bore you with the whole thing. I think the conclusion is the men of science will no doubt wrangle over this matter for some time to come. Yes, we are still wrangling over it. Meanwhile, the lay public may exercise its own humble common sense on a problem nearly connected therewith. Absolutely what's happening. The lay public is... So these dimensions, again, are not new, but they're playing themselves out in very different ways. So there's the history of vaccine resistance and questioning, but there's also the histories and politics of other things around vaccination that play out around vaccination. I just have 3 slides here, and I'll wrap up, which is an example of it. It's something we're doing in my research group, a lot of work on now. We're doing research on multiple things, but one has been around the Ebola vaccine trials, but the other has been around HPV vaccine, where we've seen multiple mass reactions deemed as psychosomatic or anxiety-related in a number of settings. But Colombia, August 2012, they launched their HPV program. She's also very happy about it, as you can tell. But anyway, they had some of the highest acceptance of all the Americas. Very successful. But then 2 years later, some of the girls, tachycardia, shortness of breath, chest pain, fainting. Of course, it was on all the evening news. First, they thought it was some kind of food poisoning, water poisoning, but then some of the mothers said, HPV vaccine? Anyone who would go on the web at this point would have seen what happened in Japan, Denmark, Netherlands, Ireland. So they had over initially 500, now it's over 600 that were investigated. A dramatic drop down to being some, as I mentioned, some of the highest. The dark blue is first dose, light blue is second dose. In 2016, 2 years later after this outbreak, it dropped to 5%. Similar in Japan, went from nearly 80% down to 0.6% acceptance. Why? Well, it wasn't just about the vaccine. And why did it only happen in this particular place? This is Colombia. This is where the outbreak happened. It wasn't spread all over. And one of Robb's points was, if only the hesitancy would be distributed evenly across the population, it would be less of a problem. What happens is it clusters. And it clusters because it's not about the vaccine sometimes. Often it's not, I'll have what she has, but I'm going to refuse what she refuses, and it clusters, and that cracks a hole in the herd immunity. It's like a tear in the fabric. But here, well, what was it about? And we saw a little bit of this, actually, interestingly, with Zika for other reasons, but 85% of the population there has been a victim of violence or forced migration, unemployment, mental health, and elevated suicide. And it's just, this is my last slide, the history of, I'm working with, thanks to Sanjoy, more and more with historians and I mean, I'm already an anthropologist, but with other anthropologists. The history of paramilitary violence shaped this was with investigations there, shaped the whole way they responded to the HPV vaccine. And most of vivid memories of paramilitary men sexually violating young, virgin, and healthy women. So it all affected HPV. Freud used to talk about conscious and subconscious. These are a lot of the histories that have gone into the subconscious, not of just of individuals, but of communities that we're seeing get played out. And vaccines, and these may not have been caused, these reactions, by what was in the vaccine, but the experience of the vaccination triggered and released a lot of subconscious histories that turn out with shaking, twitching, paresthesia. And right now, if you go to any of the national registries globally on HPV, HPV has the absolute highest number of adverse events following immunization. Those are reported, not confirmed, but a lot of these anxieties are coming out, and it's actually one of our biggest research projects we're doing together because history is playing itself out. And I won't go on because we're wrapping up, and I'd love to have some questions.
Thank you.
So, bit different. Yeah.
So, yes. So I can see that there are some questions online already, but I'd first like to throw the floor open to all of you for questions, comments, and then maybe go online as well. So please. please. And if you could identify yourself as well.
Hello, my name is Sudhir Sani. I work here at WHO Regional Office in the joint TB, HIV and hepatitis group. Thank you very much for the very exciting talks. And I'm very happy that you mentioned during your talk that we shouldn't, even if we are convinced that something is right from an academic point of view, but we shouldn't expect people just to follow and say, well, they have thought it out and they are the smart ones, which is unfortunately a mentality that is more and more happening. And this brings me to the next, to my actual question, which is about the fact that nowadays people, when they don't know about something, when they are looking for a response, when they have a question, it might be the most simplest question as, you know, how do you get that dirt away from your clothes, to very important questions, do I vaccinate my child against this or that disease? They just start asking Google. And I'm not an IT specialist, but I think what pops up as first result can be very much manipulated, even through financial contributions by that company and the person that is behind it. And I had that experience in my even friends around me that were looking at medical questions online, asking Google, look, here it's written, and then, you know, I had to go and say, but do you know by whom they are paid? Who is behind that green, very friendly background image? So if you could get to that issue and how we can prevent that now in this vaccine context would be great. Thank you.
Would either of you like to comment?
Yeah, I mean, from the public health authority perspective, there's not enough done in terms of understanding and managing Dr. Google. We don't, I mean, in most of the member states in Europe, I'm not talking about sub-Saharan Africa here and other regions, but in Europe, the visibility of the websites and reliable, robust information, simple, easy to use information, usually comes at link number 15 or something. So you're absolutely correct. That's not something I feel that there's been enough done on, but I think it's also an extremely difficult thing to do something about, because you will never be able to, as a health authority, be able to be as nimble and agile as a single individual sat on a laptop somewhere, just feeling that they want to stir things up a little bit. I mean, we have an individual, Professor Jagoda in Bosnia-Herzegovina, a single lady that has brought the program to its knees on 3 occasions with total suspension of program. One woman who is willing to talk to the media, willing to be very social media active, and willing to take the limelight. So I can only agree. I can't really answer the question, but to agree, I don't know. Heidi?
Yeah, it's very difficult. And one thing we're seeing, I've been reading some articles on this that are very relevant to the way they're looking at terrorism, actually. One of the articles that I thought really captured it was called "The Algorithms Behind Terrorism," and how they are the systems, because this whole field is the business plan behind it is the algorithms they make to create controversy and polarization. So the machine, through machine learning, they basically cluster extreme views. So if you're someone who is starting to go down that path, you attract all kinds of other like-minded beliefs. And what's happening too is that because the whole vaccination arena has become so polarized, it's an opportunity. You see politicians jumping on it. You see people seeing it as a business opportunity. A lot of the naturopathy, homeopathy, you see books. A lot of money's being made off of this. And actually, we've followed one situation where somebody set up multiple websites liking each other to get the commercial value up, and of course, totally appealing to the questioners. So it's tough. I mean, because we've tried to look into how do you kind of mitigate this, and there's a lot of money behind us not being able to do that. So it's challenging.
Thank you. Please.
Hi, I'm Jamie. I'm an intern here, and I'm also a medical student. I wanted to ask, as a clinician speaking to an individual patient or the parent of a patient, what approach should you take when trying to persuade or explore the issues about vaccination?
Say you care about what they think, for a start, I think. There's research all over the map on this. You can read one thing that says, be very open, ask them questions, and another that will say, be more assertive. I think you need to know your patient a little bit, and in principle, they want to get confidence from you. So you don't want to throw it out open and say, well, what do you think you should do? Because then they don't feel like you're confident. So I think you want to be confident in your view that it's a good thing, but at the same time be open to a conversation. I mean, that's in the broadest sense what I would say.
I think 90% of good risk communication is about listening. And I don't feel as if we're good enough listeners, because I think most GPs, when a hesitant parent enters the practice, hear half of a question, and then basically it's verbal diarrhea from the GP just giving you every piece of information about this vaccine, when you actually just wanted to ask the most simple thing. And for most parents, it's about asking the question. They want to feel that they've been heard. They want to feel that they've been given an environment in which they can ask that question. The second point I'd say on this, and I completely agree with Heidi on this, is that the best piece of advice I ever heard given was by Paul Offit's wife, who's a GP, who said, the last thing I do is allow them to leave my practice looking for another GP, because they will find a GP that agrees with them and their anti-vaccine position or sentiment. So the one thing I need to do is continue cultivating that relationship and have patience, because you'll ultimately find somebody who does listen and agree. And that's the worst case scenario.
Thank you. There's a very popular question on Slido, anonymous source, but what's next in terms of tackling vaccine hesitancy?
It's
What
a
next?
very narrow question. I think we've got to do a better job of understanding it. I think there's a lot to be said in something that Heidi brought up earlier, which is attracting different disciplines to this field. This is not a risk communicators challenge. This is not a communication challenge. Communications has a phenomenal amount to do with how we tackle vaccine hesitancy, but informed individuals are not necessarily behaviorally responsive ones. We know this from the last 30, 40 years of communicable disease prevention. We know knowledge doesn't predict action. So our starting point cannot be communications. I think we need to bring in the social sciences. We need to bring in people with medical humanities, anthropology, medical anthropology backgrounds, bring them into the party and get them to sort of assist us in insight into hesitancy and better understanding of what we need to do to tackle it.
Thank you. Sir. Sorry.
Yeah, my name is Christian. I'm working in the Division for Information and Research. And I remember I participated in a seminar with you some years ago, and we already discussed the problem that people from, in Germany, for example, or in Switzerland, people from the upper class, so to speak, of the society, they are very often well informed when it comes to alternative medicine. And paradoxically, it is the so-called well-educated people who argue against vaccination, which is quite unusual for us, which completely underlines what you have said, that communication is not the thing. But I remember that some years ago, you had the idea to talk to homeopathic patients, particularly in Germany, who recommend vaccination. And you wanted to find out how do they convince their alternative medicine convinced people to get their kids vaccinated. Are there any findings in this area?
We did do that. It wasn't with the homeopathic, it was with the anthroposophic. It was with the Steiner schools, Waldorf, and anthroposophic communities that traditionally have lower immunization rates because they believe that the fever that accompanies measles particularly is actually strengthening for the body, both in terms of its biology and in terms of the brain, even they open the portals of the brain they talk about when you have your fever as a child. So they believe it's a good thing for children to have the fever. But now the anthroposophic community has come full circle, actually, because now the leaders of the anthroposophic community have come out and said that vaccination is a positive thing, we should accept it. But at that time, we were using an approach called positive deviance, where we looked at the few people within the community, and we did it in Sweden with the tailoring immunization program toolkit that we were developing at that time, many years ago now, and went to it in Jarno outside Stockholm, went into an anthroposophic community and talked to the people that were vaccinating. Because all too often we're looking at the people that aren't vaccinating. They can't really tell us much about what would motivate them and what would get them to motivate. It's often the people that deviate from the norm positively, the positive deviants, who have the richest information and evidence to provide us. And we did that in Jarno, and the Swedish authorities took steps to then segment the anthroposophic community so they could start targeting those populations in a different way. Yeah.
Please.
Hi, I'm Laura. I'm a medical resident in public health in Italy. I'm an intern here. We had a very strange, strange story last year in northern Italy. We had a nurse that was in charge of vaccinating children that just pretended to do it. So we had something like 5,000 children not being vaccinated. And so my question is, what to do when you have a system that you should trust, but the system doesn't trust vaccines?
It's a big question. Again.
It's one of the biggest challenges we have now. I mean, and there's been also a shift in a lot of the research in terms of vaccine hesitancy among health providers, among health workers, because for all the waning trust in the world in just about everything, GPs are still standing their highest whenever, I mean, still in surveys today, a doctor is someone that at the end of the day still has a notch above anybody else in terms of influence, at least in survey work. But we have this whole cohort of health professionals, including scientists and Nobel Prize winners, who are questioning one or more vaccines. That's not the first place I've heard that story. I had someone from the health authority in Chile also tell me that it was one of the issues we had in the polio rounds. They would check that they had done it, or they would say, oh, they're just refusing, when in fact they just didn't want to walk that extra mile to go give it. But it's a challenge. And it's not just, in some cases, because they were too tired, it's because they actually are hesitant. So there is an effort now to understand better and to try to address it. But I think these are not the people that should be giving vaccinations.
And the second most popular, it's gone to the top. The next most popular question actually relates to what you just asked about what are the specific issues related to healthcare workers and vaccine hesitancy. And, I suppose from what we've just discussed, quite a double-edged relationship.
Yeah. Just from the research we've done and from what we've reviewed, it's rarely across the board. Mm-hmm. It's usually a particular vaccine or a newer vaccine or one that, like in the case of the HPV, sometimes because it's related to a sexually transmitted infection, that they're, like particularly in South Asia, some of them are uncomfortable talking about it to a parent, so they'd rather not talk about it. But mostly we see in the flu vaccine, we just did, we're just rerunning our confidence index across the 28 EU countries for the European Commission. We're just seeing that, there's a lot of hesitancy around docs recommending, for instance, the flu vaccine. It's vaccines and pregnancies a touchy time, but it's a high-risk group. How do you navigate that? So some of it you understand. They're afraid of the liabilities. They're afraid of some of the questions. So we need to do better at preparing. There's two things they're not getting in medical and training. One is there's usually very little in any medical training about vaccines. So that needs to expand. But people don't get in that profession any kind of counseling training. You're taught how to give a difficult diagnosis like cancer or HIV. That you get some training on. But you're never taught how do you handle a conversation where someone says, "Doc, I don't want what you think I should have," and they start challenging, and that's happening more and more. So one of the things that's been suggested to us by some groups is, can you come give us some training on how do we deal with these people? How do we have that conversation? Because what's happening in the meanwhile is they just shut down and say, it's okay, you don't have to have that vaccine. I want to keep the patient in mind. Yeah.
Couple of more minutes, so question, sir. Who's the mic there?
Hi, I'm Shadrach from Ghana, and I'm an intern at the Child and Adolescent Health Unit. I practiced as a nurse in Ghana for a couple of years before doing public health in Glasgow. From Ghana, where we have over 95% vaccination rate for many vaccines, it is not new to me to know that in the West, people do not patronize vaccination. But then I'm surprised that those you expect to know better almost are not patronizing it. And this culture seems to be trickling down even to Sub-Saharan Africa and other developing countries, because the argument then goes, even the West who brought all these are not taking it. These are, efforts, or these are attempts to sway you to be, or there's a trial going on, which you don't know, you are being used as a test rat, so to say. I mean, so that to be a prophet of doom, so to say, I can see the possibility that if these things are not corrected in the West, or if vaccination hesitancy increases, it could actually trickle down to other developing countries where there are even higher risk of all this communicable disease. So from that worrying perspective, I know you spoke a bit about the lobbyists and all these anti-vaccinations. Who really stands to gain in all of this? I mean, I can understand for tobacco or for breastfeeding, which is also not really taken up here. I can see who stands to gain. But how big is the industry against vaccination, and who is gaining, even when they are swaying the American president to their side? Who stands to gain, really?
Well, it's interesting. For the Ebola vaccine trials that I'm running, the communications, the trust building, and rumor management, of the phase 1 trial countries, Ghana was the country we were least worried about, because it's high vaccine coverage, and the rumors there shut down 2 vaccine trials that never happened. So it was one of these things that, they just come out of the blue, and it's true, these anxieties, the guinea pig anxieties that we think are. But the biggest reason in Ghana and in other countries is people feeling like, you didn't come talk to us first. Why did we hear this from somebody? Some journalist got a message from somebody in America that why we heard that your maternity hospital is recruiting people for a trial. How come you don't know about it? So it's one of the biggest issues. The Catholic bishop's refusal of tetanus in Kenya. Every year, the Ministry of Health involves us in these campaigns. Why didn't they involve us this time? Something's funny. And then they start digging on the internet. What's suspicious about this new vaccine? So engaging stakeholders. One thing I think, if there's a last point to make, is you know, in a lot of health, we're pretty good at trying to engage. AIDS has probably been the most promiscuous in the number of non-health partners it's involved. And in health in general, we try to, but immunization, not only is it immunization within health, it's like polio or HPV, or we need to kind of get out of our backyards, involve other people. I mean, we need to engage a lot more broadly, because the lack of that engagement is really hurting us.
Thank you. Thank you so much. And thank you both for wonderful presentations, thought-provoking ideas. Thank you for coming. All, because I know how busy all of you are, so thank you for making time to join us. Thank you to the wonderful WHO colleagues at the back who've helped us with communications today. And thank you, Victoria, for going beyond your brief. And I don't know you, but I assume you're from WHO. Thank you for passing the mic around. Thank you.